is working in Rome.
Good morning. It's a pleasure for me stay here today, and thank you to Dr. Palumbo to inviting me at this course. I am Roberta Vicario, and I speak about 3D ultrasound for evaluation of the tubes. I have not disclosed, and the objective of my talk is uh, to show you how to evaluate fallopian tube using the 3D ultrasound, how to optimize the image for evaluation of the fallopian tubes, and how to carry out the 3D acquisitions. You know that the causes of infertility are one-third to male factors, one-third female factors, and one-third to combination of factors. And between female factors, 35% is due to a tubal damage, such as adhesions, PID, previous surgery, peritonitis, endometriosis, or also tubal occlusions due to previous ectopic pregnancies. It's very important to recognize that the fallopian tube is a dynamic organ, and it's important to evaluate the motility of the tubes, the condition of tubal lumen and fimbria, and the tubal-ovarian relationship. Traditionally, hysterosalpingography has been the first level study to evaluate uterine cavity and fallopian tubes, but the improvement in ultrasound technology have allowed the use of ultrasound and specifically 3D ultrasound for this purpose. Hysterosalpingography presents several advantages such as outpatient therapeutic effect, but also he presents also disadvantages such as poor tolerability, costs, use of X-ray. You can see here an image obtained by IFOSI that is completely superimposable to hysterosalpingography. So, how can we use ultrasound to study the tubes? Usually, the normal fallopian tube is isoechoic and therefore can be visualized by ultrasound unless there is a fluid inside or around the tube, or in case of PID, salpingitis, and hydrosalpinx. For example, in this video, you can see the fallopian tube with the thickened wall that is very close to the ovary, and we can already suspect tubal damage. But in order to study the tube properly using ultrasound, we need to inject fluid through the tube, so you perform a sonohysterography. And here you see how we do it. First, we study the uterus, as you've seen in a previous talk, and you see passage of the fluid through the right tube, and then we acquire a 3D volume to document accumulation of fluid. And then we do the same of the left side. In this way, we evaluate the right and the left ovary and tube in 2D and in 3D. Laparoscopy and hysteroscopy are the gold standard exam to study fallopian tube, but it has high costs since it requires hospitalization, operating room, general anesthesia, and there are surgical anesthesiological risks and the long waiting time. So it doesn't represent the first level diagnostic approach. And for a normal embryonic implantation, we need a normal endometrial cavity, but tubal anatomy is also important. So 3D sonohysterosalpingography allows to evaluate the uterine cavity and tubal patency simultaneously, associated with the study of the structure of the uterus and ovaries. Uses ultrasound to watch the movement of normal saline injection into the uterus and into the tubes, and doesn't use X-ray or iodine dye. Indication are determination of tubal patency in patient desiring fertility, confirmation of tubal occlusion after sterilization procedures, and contraindications are basically the same of sonohysterography. So pregnancy, pelvic infection, active vaginal bleeding, and hydrosalpinx is not an absolute contraindication. 3D sonohysterosalpingography present several advantages, such as it is accurate, fast, outpatient, inexpensive, and well tolerated by the patient. Instead, a possible limitation is related to evaluation of tubal morphology. However, with the high standard ultrasound device and expert operators, a lot of information can be obtained. If necessary, we can use a specific contrast media, and I will show you some example of this. After effects are pain and vasovagal reactions, and the stenosis of the cervix is the most common cause of the sonohysterosalpingography failure. Important before to start the exam is the transvaginal ultrasound. In fact, we must sure that the patient is in the early proliferative phases of the cycle, that bleeding is stopping, and the ovulation has not occurred. Then we must setting the image, adjust the depth of view, see uterus and ovary on the same section, zoom the image of tube and ovary to see the details, and individual volumes may be stored for each side. Then we perform the transvaginal ultrasound also to evaluate anatomy, presence of pathology such as endometriosis, adhesions, fibroid, adenomyosis, uterine malformation, and for evaluation of endometrium. Important is to identify flexion of the uterus and position of the ovaries, interstitial portion of the tube, and the bladder. The IOM guideline explain that transvaginal sonogram should be performed prior to be performing ICOSY. CIS can be performed as described in the previous talk immediately prior to ICOSY. If performing an SIS, the catheter should be flushed with sterile fluid prior to insertion. After cleaning the external hose, the cervical canal or uterine cavity should be catheterized using an aseptic technique. In selected cases, a balloon catheter is used to avoid backflow of fluid during ICOSY. An appropriate sterile fluid with air, contrast, or foam is distilled slowly by means of manual injection under real-time sonographic imaging. Commercial devices that mix air and saline together to form the air-infused saline for ICOSY are available. One can produce similar results by filling a 30 cc syringe with 15 cc of saline and 50 cc of air. In summary, for SIS, we use sterile saline. For ICOSY, it's important to have more contrast, and in the majority of cases, we use saline mixed with air. Otherwise, we can use a specific contrast media, such as X-foam, which I will illustrate at the end of this talk. Analgesic and biotic prophylaxis have already been covered by Dr. Garcia in the previous presentation. This is a case of adhesions, and so it's certainly interesting to understand how the tube look like in this patient. Here you see the importance of the coronal plane, and it's important to check the tubal ostium bilaterally. In this video, you see that the tube is patent and air coming out of the fimbria. Here. This is a case of an hydrosalpinx, and you can see here the dilatation of the lumen and the thickness of the wall of the tube. Here we see the distal portion of the tube surrounded by fluid and fimbria, and the lumen is dilated. This is one case of large hydrosalpinx. And in this slide, I want to see you how VCI can help in the evaluation of anatomic morphology of the tube. But we have much more fluid around the tube. We can study the tube using the rendering mode, and this is a render of image. And we control all portion of the tube. So with the rendering mode, we evaluate tubal morphology and fimbria morphology. And we have confirmed the diagnosis with laparoscopy. Scientific Society indicated practice parameter to perform ICOSI and recommended for the ultrasound evaluation of tubal patency. Tubal patency is demonstrated by still and contrast into the fallopian tubes via endometrial cavity with either direct visualization of fluid flowing through the various tubal segments and out of the tube, or the accumulation of the fluid in the cul-de-sac, an increase in the amount of free pelvic fluid. ICOSI has been demonstrated to have an accuracy essentially equivalent to hysterosalpingogram and chromoperturbation at laparoscopy. The presence of perianasal fluid allows us to perform very realistic reconstruction, such as a virtual image. And in this image, we see the dilated salpinx and fimbria. In this slide, you can see that we confirm the diagnosis with laparoscopy. And in this video, we see how the tube is abnormal, convolute, and the wall of the tube is thick. This is another modality to reconstruct the cavity with the silhouette rendering, and allows us to have a virtual reconstruction of the cavity and therefore also of the tubal ostium. And we see the tubal ostium if we change the plane to coronal plane in sagittal plane. And this is another example of reconstruction to the other side. ICOSI with the XM foam allows us to see the tubes using an ultrasound contrast medium. And here you see the mix of air and the ultrasound contrast medium, and the specific catheter is used. Now I show you several images of high COSI with the XM foam. Here you can see how the cavity and tubes appear in a 3D plane after foam injection. And this is the ostial and medial portion of the tube in the right and in the left side. And you see the tube in all its length, bilaterally and simultaneously. We can obtain well-defined images for the tubes, but less defined for the endometrium and uterine cavity. And in this video, you can see how appear the cavity, the tubal ostium, and the intrauterine tract of tube. In conclusion, we know that the evaluation of the infertile patient should include a study of the uterine cavity and tubes. The ideal diagnostic method should be accurate, safe, easy, fast execution, non-invasive, well tolerated by the patient, and inexpensive. And 3D, 4D sonosalpingography is very good level examination for the screening of infertile patients. Thank you for your attention.